Hey guys, so for your first test, I figured that we could go over some of the different things that might be and probably are going to be on your exam, that including hemodynamics, electrophysiology, and then the sinus and atrial arrhythmias. So for the first PowerPoint that I'm going to narrate, it's going to be the basics of hemodynamics and then electrophysiology. So first slide, we're going to talk about the cardiac cycle, which we've learned throughout nursing school that the cardiac cycle is comprised of systole and diastole. Systole meaning the contraction of the atria and the ventricles, and then diastole meaning the heart's relaxation period. So when the heart is contracting and squeezing, it's having systole, and when it's relaxing and dilating to fill the ventricles and the atria, it's having diastole. So the resting phase and then the contraction phase. Basics of hemodynamics include three influencers of the cardiac output, which is the preload, the volume, afterload, the resistance, and then the contractility, which is the ventricular muscle. So I always have to think about it as preload is going to be the filling of your heart. That's why we relate it to volume. So it's the filling of your heart in the right side of your heart. And then your afterload is the resistance that your heart has to go through in order to push blood out from your left ventricle into your aorta to then go to the rest of your body. So for preload, think volume, think the right side of your heart. For afterload, think resistance. It's going to be the resistance that your left side of your heart has to push out blood to the rest of the body. And then contractility is how well your heart can squeeze, meaning the ventricular muscle tone. And that all, like I said, has to deal with cardiac output, and they are influencers of output, whether it be a high output or a low output. So now we're going to talk about the output and the cardiac index. So cardiac output is calculated by the heart rate multiplied by the stroke volume. A normal cardiac output is between 4 to 8 liters per minute. Obviously, if you have a patient in pretty severe heart failure, you're going to see that their cardiac output is less than 4. Just a side note, something that you'll learn in your nursing career, if you have a patient with a decreased output, cardiac output, important to check their pulses frequently and then monitor their urine output frequently. I think we talked about this maybe a little bit in clinical, and I'm sure you guys have covered it in class, but since your kidneys and your heart are so closely related, if you have well-perfused kidneys, you're going to have adequate urine output. If you have a decreased cardiac output, that means that your kidneys are probably not going to be well enough perfused. So in that case, you'll see a patient that has a decrease in urine output. So if, let's say, for instance, my urine output dropped to 10 mLs per hour, we're going to assume that my cardiac output is probably not the greatest either. Another thing that I want to note is that if you have a patient with renal disease and maybe they don't have a urine output, maybe they are anuric, you're not going to be able to monitor their cardiac output based on their urine output. You're going to have to look at other things, such as lactate or potentially their diastolic pressure, but that's way involved. I just wanted to clarify, if you have a good cardiac output, you're going to have a good urine output in a patient that is not anuric from renal failure. Now we're going to talk about the cardiac index. The only way to monitor your output and your index directly is through the Swan-Ganz catheter or the pulmonary artery catheter. Normal cardiac index is 2 to 4 liters per minute. Again, in a patient with heart failure, you could see an index of 0.7 liters per minute. So extremely depressed index. But again, it's hard to monitor these two directly without the Swan-Ganz catheter. Okay, so now we're going to get into a little bit of the electrophysiology. So the first thing is depolarization. What depolarization in simple terms is, it's when the impulse is initiated. So the cell wall and the cell membrane becomes permeable, allowing the cell to become positive, which then creates the electrical current. A good way to remember this is the action phase. So this is what makes the heart squeeze, is the depolarization. Repolarization is the opposite. So it's the cell's return to the original resting phase. So that way the interior of the cell returns to a negative state and allows for recovery of the cell and the electrical impulse. A good way to remember this is repolarization, it starts with an R, and resting starts with an R as well. So repolarization, resting, or recovery phase. Okay, now we're going to talk about the cardiac conduction through the whole heart. So the chief pacemaker that the heart has is at the top of the heart. It's the sinoatrial node, which is what we know as the SA node. It's located in the right atrium near the entrance of the superior vena cava. So you can see that I have it right here in gray at the top of the right atrium. We have your superior vena cava, and then right at that entrance you have the SA node. It's the chief pacemaker of the heart because it allows for the whole conduction system to go through the whole heart. So it starts at the top and then it goes all the way down to the bottom to the ventricles. Next we have the atrioventricular node, also known as the AV node, which is located at the base of the right atrium, which is right here. You can see it goes SA node and then it goes down to your atrioventricular AV node. A good thing to think about, I think it was Olivia that had asked me this question in clinical, which is a really great question. Where does those impulses go? So does the SA node go from the right atrium to the right ventricle, to the left atrium to the left ventricle? And it doesn't. So how this works is the SA node starts in the right atrium and then it crosses over to your left atrium. It goes to the AV node, which separates the AVs of the left and right atrium, and then it goes down to the ventricles. So it works in a left to right and then bottom manner. So left to right and downwards. Like I said, the AV node is located at the base of the right atrium, and this is known as the backup pacemaker. So if your SA node, for whatever reason, isn't firing or sending that electrical impulse through the top of the heart down to the ventricles, this atrial ventricular node will serve as a backup. And if this top part isn't working, this part will. From the AV node, we get to the bundle of His, which are specialized conducting fibers from the AV node. Obviously, they go through the His and then they work their way down to the bundle branches. The bundle branches separate into the right and the left bundle branches into the ventricles. So this is what creates a narrow QRS. So electricity travels down the bundle branches into the ventricles. It creates that QRS that we have, which is the ventricular depolarization. Quick little side note, I know we haven't talked about bundle branch blocks yet, but if your patient has a bundle branch block, you're going to notice that they will have a widened QRS as a result of the block. After the bundle branches, we get to the Purkinje fibers, which are the hair-like filaments that are embedded into the ventricular myocardium, which is the heart muscle. They are the last pacemaker of the heart. So the first pacemaker of the heart is the SA node, and then it works its way down to the last pacemaker, which is the Purkinje fibers, which, like I said, sit on the ventricular myocardium. So they sit on the ventricles. So here's a better picture. I'm sure you guys have good pictures in your notes, but I wanted to put this in just so that I could kind of explain it a little better. So like I said, you have your SA node at the top of your right atrium. You see your superior vena cava right here. You have your SA node, and then it travels to both the right atrium and the left atrium simultaneously. It gets to your SA node, which is right here, through your bundle of His, which is right here. It separates into the right and the left bundle branches. And then here at the base of the ventricles, these little, they look like leaves to me. I don't know. Vines, that's a better word. Those vine-like substances are the Purkinje fibers. Okay, so now we're going to talk about electrical activity for a total rhythm. So your P wave is going to be atrial depolarization. And if you guys remember what I said about depolarization, depolarization equals action. So that's the P wave is the atrial contracting. Your PR is the onset of atrial depolarization to the onset of ventricular depolarization. So your whole PR interval is the setting of your atrial contracting to the setting of your ventricles contracting. Your QRS is going to be when the ventricle actually contracts, so it's ventricular depolarization. Your ST segment is the end of ventricular depolarization, so it's when the ventricle is done contracting, and it's going to be when it's starting to repolarize, meaning it's resting. So that's what your ST is. It's the ventricular depolarization end and the start of the heart's relaxing. Your T wave is going to be total ventricular repolarization. So your heart's electrical impulse is done on the T wave, the ventricle is resting, and then you'll loop back around and you'll have another P wave. So this is kind of the cycle, and this is the, I'm trying to think of the best way to say this. You always start with a P wave because it's in the atria. Your QRS is the ventricle, so it kind of works its way down this way. Again, this is for a patient that's in a normal sinus rhythm. Not everybody's in a normal rhythm, but we'll get into that. This is just the basics of the electrical activity. And if you guys have any questions, if I didn't explain something well enough, please just come and talk to me. So like I said right here, you have the start of your atrial contraction, so you have your P wave. You have your PR segment, which we talked about was the atrial depolarization to the ventricular depolarization. You have your QRS, which signifies that your ventricle is contracting, it's depolarizing. You have your ST segment, which is the end of ventricular depolarization and the start of ventricular repolarization, so it's starting to rest. And then at your T wave is when your ventricular is repolarizing and or it's resting. Right here, that's just a U wave. Not many patients have it unless you have hypokalemia. So if you have a potassium level less than 3.5, sometimes you're going to see that your patient has a U wave. Not to be confused with the start of another cycle, electrical cycle. That U wave won't be as prominent as a P wave. Okay, so that's the end of this PowerPoint. Sorry. If you guys have any questions about that, please just let me know. I know we kind of went over that relatively quickly, but I wanted to do the basics of what you'll need to know, and I'm going to upload this to YouTube. That way you guys have it. So let me do that now, and then I'll send this to you in an email. Okay, bye guys.